I'm Rob Spinner. I'm the former chair of neurosurgery. I'm really delighted to be the honorific moderator of a session I can't even pronounce. But it's on brain-computer interfacing and neuromodulation for circuit disorders. Now, as an ex-chair, you get a little bit nostalgic. You also are looking for the meaning of life because things have changed. With that in mind, I am so proud of being part of this because the momentum that I feel is part of the vision that I had and shared with Claudia Lucanetti and even Bob Brown in his brief tenure. But we put together lots of paperwork for centers and things of that sort, and really delighted to see the synergy that's developed between all of the groups that are here. I think as an ex-chair, the only talent I had was being a talent scout. And I look at the program, and many of the people that are here are people that really were part of the vision. I'm going to start with Greg Worrell because, I had nothing to do with his talent. In fact, Greg and I were residents years ago, and I always thought, Greg was senior to me, so I always thought I would be as smart and as innovative as Greg because he was a year ahead of me. So in 1 year, I hope to achieve what Greg has gotten, but it's really been with tremendous pride that I've watched his career and his insight take off at Mayo. Greg and I were both thinking about going to another place, Cleveland Clinic, when we were residents, and I remember a very momentous occasion riding the bus before all the bold forward construction. So about 26 years ago on a bus, talking about the greatness and the potential at the Mayo Clinic. Greg, you've done it all, and as the senior avuncular figure here of this group, I really just say I've watched things with awe. So Greg, we're in different departments, but I keep a pulse on your talents and what you're doing, and thank you for being part of everything that we've tried to cultivate in neurosurgery, and I'll introduce our story later. But Greg, why don't you take things forward?
Thank you very much, Rob, and it's always been a pleasure. I always thought you were older than me, though.
Nope, you're...
So I'm going to talk largely about epilepsy, but a lot of this will span all neurologic and psychiatric diseases, are many. But I think as Brian actually, and he and I have talked about this a lot over the years, it's really a disease that captures many of the challenges. One of the challenges is it spans the lifespan from infancy to the elderly. So if you're thinking about neuromodulation, building devices, making therapies, I'm looking for Tim, you really got to think about what you can do for children, infants, in addition to adults. So it's many diseases as well. So it's a very heterogeneous disease. When the lungs are irritated, you cough. When the brain is irritated, it most often seizes. So it's very heterogeneous. About a third of the people are drug resistant. So about a third of the 60 million people in the world with epilepsy continue to have seizures despite taking medicines twice a day, every day. It's not only the seizures, the comorbidities. Actually, patients will tell you, I have these sporadic seizures, but what really messes me up is I can't remember the grocery list, or mood. I don't sleep well. So the comorbidities, again, these are common to all, I would just say almost all neurologic and psychiatric diseases. It's the same comorbidities, memory, mood, sleep. They're always involved. So if you can understand those, you could potentially have an enormous impact. Epilepsy also, it's a paroxysmal disorder that doesn't leave a signature. Think about you're designing a therapy for events that occur randomly or seemingly randomly. When they pass, they're done. They may be amnestic events. So fundamentally, Patients are very poor reporters of their seizures. There's no, unless they bite their tongue or have some unfortunate trauma related to the seizure. So it's very difficult to track the disease. So we think progress can be made. One, it's a disease of networks. The brain is a complex network. These comorbidities largely reflect the mechanism of the disease. So say the hippocampus, one of the most common areas causing seizures, when it's not producing a seizure, it's doing fundamental work. It's doing fundamental function for memory. Many similar examples. So understanding these networks, and if you can target them, you can make progress. We need biomarkers, and I think as Kendall said, they can be electrophysiologic, they can be neurochemical, there can be a wide range of biomarkers. There's not just one biomarker. And then with that, the hope for personalized neuromodulation. So as we've approached this from a platform ecosystem perspective, and I always give hats off to the dogs. Everything you know about human epilepsy, everything I just told you, I don't know that the dogs have bad memory, but they probably do. But epilepsy is very common in dogs. It's commonly drug resistant. They're large enough to accommodate the human device. So that's been very important for our preclinical work and development of devices. And we've been interested in this idea. Medical electronics moves very slowly. If you can integrate the data, get the data off the device onto a handheld, I'm reaching for my phone, I don't have it, then you're moving at the speed of commercial electronics. And there's few things in the world that move faster than the technology of your iPhone. So if you can make that integration, that bidirectional connection with devices, integrate that with the cloud, then you can really move at accelerated speeds. So how do you do this? How do you make this ecosystem? Well, you need devices. You need devices that can sense, that can stim, that have wireless connectivity. Of course, they have to stimulate. They have to deliver a therapy, this idea of a bidirectional platform. Then you can ask questions like, where do we stimulate? What nodes? Where in the network? And then we can deliver therapies and track outcomes. We can track memory, mood, and sleep. So that's been the playbook for the last 20 years. So here's, and it takes so long. Someone mentioned that. So I'm going to just give a brief history here of how we've been doing this. So it started with this device, startup company, NeuroVista. It was my first trip ever to the FDA. They totally didn't get it. What, you're going to put electrodes in the brain, you're not going to give a therapy. We said, no, we're just going to do forecasting. We're going to forecast when seizures happen, tell the patient they can sit down, maybe take evasive action, or they could take a drug. There was no way it was going to fly. And if you're familiar with startups, boy, they're not going to wait a long time. They can't wait a long time to make that regulatory path. So this device went to Australia for the human trial. I say we did reverse translation. We did it in dogs here in the US because we couldn't get it through the FDA. Got a nice NIH grant, demonstrated forecasting. I think Ben Brinkman's in the audience. This was really, I think, a landmark paper in 2016. It took a long time to get to that paper. The company folded, and the next step was this. So the Brain Initiative, NIH Brain Initiative had a great idea. Public-private partnerships. How do you get academic institutions working with device companies, all the regulatory pieces? This time when I went to the FDA with Tim and his partners at Medtronic, you really had the sense we're pulling in the same direction. So this device, we again did preclinical work in dogs. We actually implanted 3 pet dogs with epilepsy, which was, we learned a ton because now the dogs living at home with their owners, they're doing the charging. They're experiencing the difficulties with the time that it takes to charge, how you maintain the wireless connectivity. All that was incredibly valuable when we moved to the human studies. And ultimately, we implanted 10 people with mesial temporal lobe epilepsy with this device. And I'll talk about this more. This was a really just a blast, actually, and we learned so much. We're currently working with this device, Cortec, and with Kai Miller as the PI. We have a nice U01, and Nuri Inche has NIH funding for this. So we have this implanted in a dog. First dog was implanted in 2022. And then the most recent device that we've had the opportunity to be involved with, and this is a Mayo Clinic company that Mayo's deeply embedded with, and we've licensed technology to them, Cadence Neuroscience. We've implanted, again, large animals, a dog with epilepsy and actually a pig model, and we're on path to a pediatric and adult trial by the end of this year. So that, just to highlight the timeline again, boy, we got to go faster than this. It's way too slow. The patients want it. The patients need it. It's our job to deliver it. So just a quick flash of the Cadence approach. So we saw, Brian showed the stereo EEG. This is a workstation. This is basically what is embedded into a device. So at the bedside, you can test stimulation, optimize the therapy before you put the device in. And the device looks like that. It's a 4-lead, 16-channel, rechargeable, sensing, wireless connectivity to an Android phone. So we think that's a glimpse at the future. This is the back end of that, what we call BrainRISE, Brain Restoration Intelligent Stimulation Ecosystem. This is for epilepsy. These are the patients that we have living across the country. We actually have another interface for canines and different trials, but with this, we can catch seizures while people were out living their lives, identify the patterns of their seizures in very large-scale data. We've had patients now out for multiple years with these devices while delivering therapy. And engineers will appreciate this. You can track the battery, the stim rates, so you can get a lot of useful data. And here we display hypnograms and spike rates. So that was supposed to run. There we go. So this is an early at UC Davis. Bev Sturgis was the neurosurgeon. Griffin has epilepsy. I remember talking to the owner. She goes, well, how do you think, is this going to work? Well, we've tried it in a number of humans, and we're getting some pretty good results. So here, that was streaming hippocampal data in a navigation experiment. It's not so sophisticated, demonstrating that dogs like food. I think we already knew that, but there was a nice hippocampal theta if you would have done the spectral analysis there. So from that preclinical data, that preclinical work in canines, we moved on to human epilepsy, and we implanted 5 patients with mesial temporal lobe epilepsy with this device that Tim Dennison's team developed at Medtronic. It was 4 leads, so we could target 4 nodes in a network. So that turns out to be very important as you're trying to, say, improve memory, treat seizures, improve sleep. So this is a classic network in neurology, PAPE circuit. And this was the team. Jamie Van Gumpel and Kai Miller implanted these 5 patients. There's 5 other patients that have CL stimulation. And then Brian Lundstrom and Nick Gregg, myself, were the neurologist on this group. And so we collect all this data. What can we do with that? So we have the data from the old days, from the NeuroVista data set, in dogs and in humans. Years of data. Same with humans. So now you can build a very good seizure detector. You would think, boy, aren't there already seizure detectors? But the fundamental, the primary thing you want to treat in epilepsy, we still don't have good tools for tracking that. It's pretty remarkable. So we took a very principled approach here. Vladimir Sladky, Václav Krimin developed a convolutional neural network for this, and we did the validation and testing, and then prospective testing out in the field, again in dogs and humans. And you can make a very good detector. Once you have that detector, this just shows the performance in 2 dogs at UC Davis and 4 of the humans. What you find, and this was known, we weren't the first to show this, but we're the first out with people living their lives. If you look at detected seizures, that is, people out living their lives, EEG seizure, the classic signature, the biomarker of the seizure, versus patient-reported seizures. This is in the 5-patient cohort. If they were perfect, it'd be right along the diagonal. You can see it's all over the place. Some people report things that aren't seizures. Some people have a lot of seizures and don't feel anything, or they don't remember the seizure. So when I see the patient in the clinic 3 months later, they say, oh, I'm seizure-free. Why don't you let me have my driver's license back? Well, we know this is a problem. We know this is a problem. So patients aren't good reporters of the primary outcome. This comes back to epilepsy being a very challenging disease in that respect. They don't have a tumor that's growing that you can image and see that's paroxysmal disease that doesn't leave sequela behind. So once you have that electrophysiology, you can do other things. So you can simultaneously record intracranial EEG with polysomnography and develop a sleep classifier. So here, using AI tools, demonstrate that low-frequency stim, high-frequency stim, you've got to build different classifiers depending on how you're treating the brain. But that you can do, and then you can start asking questions. So this was a fundamental test of low frequency versus high frequency, 2 Hertz stimulation of the anterior nucleus of the thalamus versus what is the FDA approved 145 Hertz anterior nucleus of the thalamus, demonstrating that low frequency does no different than high frequency. So I say, well, that's pretty interesting. What about the sleep? Well, it turns out low frequency stimulation has much better sleep performance. Again, we've got this classifier, data streaming off the patient while they're out living their lives, where we can quantify sleep. What about memory? Well, we have this direct interface. We can test their memory, not at every 3 months when they come back, but we can test it out in the field. It turns out patients' memory is better with low frequency versus the current standard of care. So this really just points to the idea of the ability to do personalized therapy. So I'm just going to flash through this. This is seizure happens, your watch starts talking to you. We can actually start looking at what the impact of seizures are on people. We can directly probe the brain. And then we can look into the future. Here just showing with a viral construct, we can actually control the cellular entities in the brain with light. This is the revolution of optogenetics. It's going to be well, I won't make a prediction. It may be a while before this gets into humans, but you can definitely control mammalian brain. We'll just say that. So we think the future looks like this. The future's now. Interfacing devices with handheld, wearables, cloud infrastructure, quantifying the disease, personalizing the therapy. Thanks.